for the opportunity here. So let's look at primary vitreoretinal lymphoma imaging and therapy. The patient is a 70-year-old male who has defective vision since 3 months. It's a cardiac patient on treatment. He has loss of appetite and loss of weight since 6 months. And vision is good in the right eye, 6/18, left eye is 1/60. Anterior segment is normal. The fundus showed by both eyes there were mild vitreous haze along with yellowish subretinal deposits in both the eye, and OCT showed this confluent hyperreflective subretinal band which was obscuring the outer retinal details as well, with undulating RP with sub-RP hyperreflective material, and there were areas of intraretinal deposits also. Similar picture in the left eye, as you can see here, there is a confluent hyperreflective subretinal band obscuring the outer retinal details. Sub-RP, RP undulations were significant with sub-RP infiltration. Also, there were areas of intraretinal deposits in both the eyes. Autofluorescence showed it showed hypopigmented hypoautofluorescence patches with a ring of hyper autofluorescent, both in a leopard skin pattern. And the fluorescent angiography showed round hypo, early phases showed round hypo areas with late granular hyperfluorescent spot and disc staining. Similar picture was seen in the left eye. And at that point, we considered the diagnosis of posterior uveitis with vitritis, also primary vitreoretinal lymphoma and other paraneoplastic syndrome. But complete blood workup and the uveitic workup, including Manto X-ray chest and TPHA, toxo, everything was negative. An oncologist referral for metastatic workup. PET scan was normal, CT chest, ultrasound abdomen and MRI brain was normal. No primary or secondary tumors were detected. ERG was also within normal limits. So with probable diagnosis of primary vitreoretinal lymphoma, we went ahead with a diagnostic core vitrectomy, vitreous biopsy and intravitreal methotrexate. And the vitreous biopsy came as low-grade non-Hodgkin's lymphoma, and showing these lymphoma cells with large lymphocytes with scanty cytoplasm and large hyper-segmented nuclei with prominent nucleoli. And immediately after within 1 week of injection methotrexate, it was seen that the vitreous haze was much better in both the eyes. The OCT showed the breaking up of the subretinal hyperreflective band, and the outer retinal details could be seen, started appearing well. And even the sub-RP undulations and deposits have started going. But with a second injection methotrexate, a week later, the less significant response was seen, though there was patchy breakup of these infiltrates. So we switched to intravitreal rituximab injection, which is again convenient monthly injections and safer than methotrexate, since we have a tissue diagnosis here. So subsequent injections of intravitreal rituximab injections, you can see there is a good clearance of the infiltration, both subretinal, sub-RP and intraretinal infiltration. Even in the left eye, you can see that the infiltrations are much better at the end of the therapy. There was a well-delineated subfoveal hyperreflective band remaining, but outer retinal details are well seen. This is probably a subretinal fibrosis, showing the end point of a therapy here. Here again, showing the pre and post treatment. The right eye, in the right eye, showing an improvement to 6/12 vision in the right eye with clearance of the infiltrations, and the left eye improved to 660 vision and good clearance of the intraretinal subretinal infiltrations. But probably there was the subfoveal fibrosis that was limiting the visual improvement here in the left eye, which was more advanced than the right eye. So patient, after 3 more months of follow-up, was lost to second wave of COVID-19 lockdown. So why this case? Because it was PVRL is a notoriously difficult diagnosis to make, especially in the early stages of the disease, where only eye is affected, and similar to our patient here. and it usually masquerades a posterior uveitis and delays the correct diagnosis in an ultimately life-threatening condition. So we need a high index of suspicion. And OCT, I wanted to highlight the OCT and fundus autofluorescent features, which are almost pathognomonic with confluent subretinal hyperreflective band that is seen, and biopsy is the gold standard, and high false negative. So it's important to have a careful sampling with low cut rate and undiluted sample, and immediate shifting within 1 hour to the lab. So prompt diagnosis before the CNS involvement, there is a better survival, prolonged survival rate, and multi-specialty approach is important. And PVRL isolated to the eye monthly. Now we have intravitreal rituximab injections, which is current best option, and further studies are needed for defining the treatment protocol. Thank you. And